I'm Bernard Gersh at the EHJ Today at the ESC meetings in London, and with me is an old friend, Gilles Montalescot from Paris, who presented today. Congratulations on your trial, the ALBATROSS Trial. I was particularly impressed that you got the French government to pay for it, which is something we've not been that successful in doing. Gilles, welcome. I wonder if you could just quickly set the scene, the background of the previous trials of aldosterone antagonists leading on to your trial today.
Yes, as you know, this class of drugs has been very successful in heart failure. We have the Emphasius study, we have the Ephesus study showing reductions of deaths with eplerenone in heart failure.
And one of the trials, I think it was Rails' heart failure, but the Ephesus trial was heart failure or diabetes post-MI and an ejection fraction of less than 40%.
Exactly. So it was not a myocardial infarction trial. It was mostly heart failure patients. It occurred after a myocardial infarction, several days after, with a low systolic ejection fraction, and there was a reduction in mortality. The question was, there was a post-hoc analysis in this study, if you remember. The investigators found out that the benefit was confined to the patients who were treated early. And early was between 3 and 7 days after myocardial infarction. So we wonder what it would be between the onset of MI and 3 days. Right. So this is the time window we have looked at also in ALBATROSS. And last year in the European Heart Journal we published the Reminder study, which was a European study in STEMI patients, no heart failure. And we randomized these patients for eplerenone versus placebo, double-blind. And in more than 1,000 patients, we showed a reduction of the primary endpoint. But in this primary endpoint, we had the BNP levels of the patients, and so it drove the effect.
It wasn't mortality, and it wasn't designed for that, really. So it was a composite endpoint with BNP. Yeah. So that now take us on to the ALBATROSS. What's the difference between that and the ALBATROSS trial that you presented at this meeting?
So in the ALBATROSS trial, we have a clinical endpoint. And what we did in ALBATROSS is to take all comers with a myocardial infarction. So it could be ST elevation myocardial infarction or non-ST elevation myocardial infarction with a TIMI score of more than 3. And we randomized these patients for spironolactone versus standard of care.
Starting when?
So starting as early as possible. And some patients were even treated in the ambulance. We use the IV formulation. Yes, we use potassium conrenoate intravenously in the ambulance in many patients, and then spironolactone. So they were treated very early.
And obviously there were some exclusion criteria like renal failure or chronic kidney disease.
Yes, patients known to have renal failure or to be on dialysis were excluded, but it was impossible, for example, to exclude patients on the basis of a creatinine level. Right, we did not have it. So the safety was also an issue for this trial. And they were randomized, spironolactone versus no blockade of the aldosterone.
How many patients?
And we recruited 1,600 patients.
And background of standard therapy, beta blockers, aspirin?
Everything else was, yes. And PCI in more than 80% of patients. STEMIs and STEMIs.
So primary PCI for the STEMIs?
And PCI, which was delayed in STEMIs.
And what sort of time interval?
Oh, it was primary PCI, very short.
No, but the non-STEMI.
Next day PCI.
Yeah, and you've done previous trials showing that we can do that.
Yeah.
I think everybody's very grateful to you because you showed that we don't have to get up in the middle of the night to do non-STEMI.
Exactly. That was another
prior trial you did.
Important for the physicians.
Important for the physicians.
And
so the results?
Yes, we had a primary endpoint looking at deaths, cardiac arrhythmias, heart failure. Actually there was no impact whatsoever of this strategy on this primary endpoint. So we were disappointed by this result, and secondary endpoints were also neutral. Hyperkalemia, 3% of patients, so good safety. Actually this number is even lower than what we have seen in the past in other trials with this drug. But
the secondary endpoints were also neutral?
Yes, also neutral.
Including BNP?
We did not have BNP.
Okay.
And But what we did is to look at the STEMI subgroup, which was pre-specified, and we found a significant interaction, STEMI versus non-STEMIs, for death. Highly significant interaction and a big reduction of mortality in the STEMI group with aldosterone blockade. So we started looking, and it was not in the presentation, but we started looking at the other endpoints in STEMIs, and they all go in the right direction.
So that's death, heart failure.
Yeah, that's death, heart failure, VTVF, and you know, when we look at the results, it's a neutral result globally, but in the STEMI cohort of patients, there is a big question now. Is that real? And if it is real, we need to do a second trial.
Yeah, I mean, to me, I found that aspect of the trial somewhat reassuring, because it's really consistent with the previous trials, at least with the Ephesus trial.
And a reminder also.
And reminder also. So I'm not surprised in a way that maybe with non-STEMI there's no difference. But I would have been surprised if there was nothing in the STEMI arm.
Yeah.
And I suppose now, I mean, the mortality difference you describe, it's underpowered for that.
Absolutely.
So what do you think the next step is?
Yeah, the next step should be a new trial. But, you know, this one took us 8 years to have the protocol done, to get funded, to start the administrative process, to recruit the patients during 4 years, wait a year to present the results. It's
yeah, and a new trial would be confined to STEMI patients.
And don't forget, we are dealing with generic drugs, so nobody is ready to pay for such a trial. We were funded by the French Ministry of Health, as you said, by the foundation, which is called ICANN, and by our group, Action Group. You know, this next trial should be larger, so it would be also more costly.
So let me ask you a difficult question. You've had a lot of experience with the guidelines, and in fact, I worked with you under your chairmanship of the guidelines for stable coronary disease and revascularization. Let's say we're not going to get a trial, and we all agreed that we would like to see one. But we have what we have. And when the STEMI guidelines come up again, I'm sure you're going to have a lot of influence on them. And what do you think is a reasonable recommendation that we can make based upon this trial of yours today, given what we have in terms of the background trials, the prior trials?
Before that, what we will do is to present a combination of Reminder and ALBATROSS STEMI together. We would have more than 2,000 patients. I can tell you the results look very good. But you know, the guidelines will have to acknowledge the fact that when you have a myocardial infarction and heart failure, it's a very good indication for the drug. If you don't have heart failure, but if you have severe left ventricular dysfunction.
Or diabetes.
Or diabetes.
To go back to the the Ephesus trial was diabetes.
Yes, but they had also heart failure. The question comes now, if you don't have heart failure, knowing Ephesus, Reminder, and the STEMI group of ALBATROSS, these patients are exposed to do heart failure because they have severe left ventricular dysfunction after the MI. You may question the prescription of spironolactone or eplerenone.
So let's say, I mean, nowadays we don't see the severe LV dysfunction patients like we used to. With early reperfusion, we're not. So the majority of the patients we're going to have and see will be patients with probably mild LV dysfunction. Are we going to recommend an aldosterone antagonist, despite the fact that you had a positive result in STEMI patients?
It's not enough. It's a subgroup, and it's secondary endpoints. We need more, and that's where we would like, you know, foundations, Ministry of Health to come up and say, we ask you physicians to use generics. We are going to support a large trial to show that a generic drug that costs nothing can reduce deaths in these patients.
I think it is the job of foundations and governments and those sort of organizations. Last quick point. So patient comes in with a STEMI, successful primary PCI. You show in your meta-analysis a benefit for an aldosterone antagonist. Would you then say if there is LV dysfunction, it should be used, but not if it's preserved LV function?
I would say it may be used.
May be used.
2B.
2B, level of evidence?
B.
Congratulations again on achieving this, completing this trial.
Thank you very much.
Thanks, Gilles.